everyone. Thank you for joining today's sessions. I'm Dr. Lalita Kavilai from Department of Public Health Nursing, Faculty of Public Health, Mahidol University. Today's topic is caring for person living with dementia in community setting. Let's get started. First of all, I would like to introduce you about dementia statistics. As people live longer, so the number of persons living with dementia is also increased. From the WHO report, they found that we have more than 50 million persons living with dementia in the world. And in every 3.2 seconds, we have one new case that diagnosed with dementia. Recently in Thailand, we found more than 600,000 persons living with dementia and is expected to increase to 2 million by 2050. We, as a healthcare provider, so we have to understand the disease and the local resource to support persons living with dementia and their family caregiver, because most of persons living with dementia were taken care by their family members in the community settings. There are many types of dementias, like more than 100 types of dementias, but the most commonly found is Alzheimer disease and vascular dementias. Alzheimer disease is caused by abnormal protein buildup in and around brain cell. When the brain cell become affected, it also decreases chemical transmissions between brain cells. So the person living with dementia will have a problem with their memory, so they may become forgetful of the name of people, place, appointment, and the important in their life. Some people might get frustrated because they have increasing memory loss, and someone may become more social withdrawal because there are lack of confidence to communicate to other people. When the dementia disease progress, so the symptoms become difficulty to perform daily activity, daily living. So we have to support person living with dementia and their family caregiver. So we have to provide assessments and then provide the support that they need. For vascular dementia, so the cause of vascular dementia is caused by vascular events such as strokes, so the damage to blood vessel and restricting blood flow to the area of the brain, resulting in reducing the blood oxygen and nutrition supply to the brains, and some brain cells become die or damaged. So vascular dementia can appear suddenly with the last stroke or can develop over an extended period of time with a series of small strokes or damage to a small blood vessel into the brain. So vascular dementia, people will have a problem with their thinking, their concentrations, and their communications. Some person might develop depressions and anxiety accompanied with the dementia. And we also see the presentation of stroke such as physical weakness or paralysis. And we might see some person who have severe confusions or deliriums. And with the diagnosis of vascular dementia, the disease progression is trend to step down presentations. So from the definition, you can see that it's not just all about memory loss, it's other functions that also affect. Dementia affect how the brain normally works, so you can see that it depends on which part of the brain that was affected. So some person may have a problem with their problem-solving skill, their planning, their thinking, or their behavior changes. Some person may have a problem with their mobility or balance. Some person may have a problem with their language and speech. So it depends on which part of their brain is affected. And it is important to look deeper. You may say that my grandpa keeps asking the same questions. Is he becoming dementious? It's normal to forget in older adults, but we have to look deeper. So you have to know what is the difference between mild cognitive impairment and dementia. Cognitive impairment is commonly found in older adults, especially in people that age over 60 years. We found that 15% of them have sufficient cognitive impairment to warrant the diagnosis of dementia. For mild cognitive impairments is the term for individuals who fall between the cognitive changes of aging and early dementia. So the person with mild cognitive impairments may have an impair of one cognitive functions or more than one cognitive function, but they can perform activity of daily living by themselves and they can perform their instrumental activity daily living. So they can prepare meal for themselves, they can paying for bill, they can going for shopping by themselves independently. But for person with dementia, so the person with dementia will have an impairment in intellectual function that affecting more than one cognitive domain, and it also interfere with social and occupational functions. For example, this person might not able to perform instrumental activity daily living by themselves. They might not able to pay bill. They're not able to shopping, not able to preparing meal for themselves. But they can still perform activity daily living for themselves, such as taking a bath, eating, toileting. So you can see that the progression of disease is declined from the previous level. So this table provides a summary for the difference between mild cognitive impairment and dementia. So it is important to identify older adults with dementia earlier, because if we can screening for the person with dementia early, so we can plan ahead for the treatment for their family, which can relieve their stress and improve their quality of life. So for screening, you can do as a population-based screening or through target case finding. So in case that you don't have more time to screen all the population in your community, you might target someone who have a high risk factor, such as the one who have history of the neurological disease, such as stroke or Parkinson's disease, or someone with the increased cardiovascular risk, such as person who have hypertension or diabetes, or when a family caregiver or the patients that concerns about their cognition and functioning, or they complain that I always have a problem with my memory, so might be got dementia. So in this group of people, you have to concern to early detections. So the key clinical process to be followed. So when you screen for the patients, so you have to carefully take the history, because it is important that you get the timeline for their cognitive change from the past until now. So you can get history from their family caregiver and also from the older adults themselves. And you have to evaluate the reversible cause of the cognitive impairment, whether it comes from a medication or substance that they use or not. So you have to review the medicines and substance that they use. Next, you have to perform the cognitive screening test. So mini-cog is one of the tests that's commonly used in the community, which takes just only like 2-3 minutes to screen for person with dementia. And in the community setting, you might not have a chance to do the blood work or neuroimaging. But in hospital, when the patients was like screen positive for the cognitive test, so you might transfer the patient to find a specialist, and they're gonna complete their blood work and do neuroimaging such as MRI brain or PET scan. Here is the test that we use to perform screening. We call it mini-cog. Mini-cog is the screening tool that we use. So we ask the patient to remember 3 words. So we can give any word like banana, sunlight, and chairs. So we ask them to remember these 3 words, and then you will go back to ask them again. So during we were waiting, we asking them to drawing a clock. So you have to instruct them to draw a clock in a circle shape with 1 to 12 numbers, and you have to have a small hand and big hand of the clock with the time at 11 and 10. So you ask them to draw a clock and check for the accuracies. After that, when they complete the clock drawing, so you ask them to repeat that 3 words again. So you have to see if they're able to repeat any word. So if they can repeat all 3 words, so that they not have a memory problem. So you might have a screening for next 6 months or 1 month to follow up regular routine to screen for the memory for that patient. Or if they cannot recall any word, so this person may have a problem with the memory. So you have to transfer them to see the specialist. And if they can remember about 1 to 2 words out of 3, so you have to check whether they can draw a clock completely, correctly with 11 and 10. If they can not draw the clock correctly, so you have to refer them to see the specialist. Okay? So you can practice by yourself, remember 3 words, and then clock drawings. Okay. Next, our goal of care is to remain safety at home and delay admission to the long-term care. For the community-based interventions, several community-based interventions or support have been shown to delay or prevent admission to long-term care, including in-home multi-component interventions or community support program, education and training program for caregivers, daycare program, or other forms of respite care or case management of dementias. Caregiver education is very important intervention. From the meta-analysis, it shows that it has a significant reduction in the risk of admission to long-term care, which take about 12 to 18% reduction in the proportion of individual admission to the long-term care. And also for the case management is associated with the reduced admission to long-term care relatively to usual care at 6 and 8 months. So case management for person with dementia is involve the use of standardized protocol for assessment, case management support, and coordination of community service. So this is the table that we use to assess for the person with dementia and their family caregiver. So at first, we assess their activity, daily living, whether they have any problem to perform basic ADL or not, such as they can taking a bath by themselves, they can eating, toileting or not, or they need any assistance for family caregiver. So if they need any assistance from caregiver, so caregiver need to be trained how to help person living with dementia with activity daily living. Second one, we're gonna assess about their behavior and psychological problems, because some person of dementia, they might have aggressive behavior or they may have sleeping problem or hallucination. So this problem is resulting from the disease. So you have to provide the knowledge for the family caregiver that it is because of this disease, not because of the person themselves. So they need to understand and learn how to manage with the behavioral change of the person living with dementia. For the cognition, the memory, so you have to assess how progress of the memory loss, and you might advise caregiver to provide support or promote cognition of them by encourage them to go to support group or playing board games, something like that, to promote activity of daily living or to maintain their function. Okay. For the drugs, so you have to assess and review the medicine that they use, whether they can take the medicine correctly, because some person of dementia, they just don't like to take the medicine. Some of them just pretend to take the medicine and then they split it up. So you have to make sure that person living with dementia get the correct and sufficient dose of medicines, and you have to observe whether the caregiver can manage the medicine for person living with dementia or not. For the environment, so you have to ensure for safety environment in the home to prevent fallings or any accident. So you have to observe housing environment where they have sufficient lights, any space that leak for fall, something like that. So you have to observe their housing environment. Family and caregivers. So you have to see whether the family have any stress or burden, or they become like anxiety or depression, because caring for person with dementia is difficult, and because one problem is the communication. So you have to ensure that the caregiver is understand what person living with dementia need, and also they can manage with their stress and burden. Is there any support from other family members? So you have to assess that too, to help and support family caregivers too. So as we talked earlier, goal of care is to remain activity daily living, remain safety, and delay the long-term care admissions. In addition, we have to see for the legal money for the person living with dementia, because we consider that person living with dementia is like someone with disability, and they cannot perform or making any judgment by themselves, so they need someone to taking care on behalf of them. Like when you go to the bank, so they cannot withdraw the money by themselves because they may have a problem with that judgment, something like that. So we have to use the legal to have someone to perform, to acting as the one who taking care of the person with dementia. And the last one is the network. So you have to understand that we have to manage and arrange the support group for person with dementia and their family caregiver, because they can share their experience and knowledge and share their concern together, because caring for person with dementia is quite difficult. So if we have another kind of social support, it can help them a lot. It's about the caregiver stress. As I said earlier, that stress is common among caregiver or person living with dementia, and caregiver stress is also associated with the placement of patients in long-term care and poor mental health and medical outcome among caregivers themselves. For example, some caregiver become stressed and resulting in depression or anxiety. Someone may have like high blood pressure and increased risk for hypertension, something like that. So we also have to take care of the family caregivers. So I would like to share about my study, coping strategy and quality of life among Thai family caregivers or person living with dementia. So I recruit about 86 participants in Thailand, and then I identify the association between coping strategies and quality of life, and I found that positive emotion-focused coping strategies is associated with improved quality of life among family caregivers. So what is positive emotion-focused coping? Positive emotion-focused coping is the strategy that caregivers use to cope with their stress, such as social support and acceptance. So these are examples of coping strategy that they use to cope with their stressful and help them to improve the quality of life, to have a good quality of life. So we have to provide educations and make understanding for family caregiver until they can accept the disease understand the disease progression, so they can accept person live with dementia, they can accept the caregiving role, and they can accept the cause of the disease. When they're able to accept, so they can manage with their stress for themselves, and it's good for their quality of life. And last but not least, this is the evidence gaps that I found from the review literature from Canada. So this is like the summary from the review that you can apply for your work or your future research. So they said that there are still lack of evidence in the research related to community-based services for dementias, particularly in the area of respite care. We also need a randomized control trial that evaluates the effect of case-finding approach for identifying older adults with dementias. And we also need the intervention that help to reduce unnecessary admission to hospital or an use of their emergency department among older adults with dementias. And for the caregiver interventions, we still need to know what are the important elements that we should have in the multi-component intervention to manage the stress of the caregiver. And last, we don't know the effect of specialists in dementia on outcome in people with dementias. So we have to have a great knowledge about the benefit from the specialist involvement, which require additional research. And if you have any further questions or concerns, so you can email me at lalita.kae@mahidol.ac.th. Thank you.